A little different today. Quiz. You're going to ask to provide a diagnosis, differential diagnosis for 3 plantar foot pains. Pain at the heel pad, pain just distal to the heel pad, and metatarsalgia. Do your best with it. There's more causes than you may think. And if you don't get them all, don't worry about it. Just correct the knowledge gap. That's all you can do. And this is probably the best way of learning what you don't. It is the best way of learning what you don't know, to actually test yourself and then deal with what you don't know. All right, good luck with it. Take care all. Bye.
I know that pain in the foot can be referred from the lumbar spine, the knee, the ankle, and even the viscera. But for this webinar, we're interested in local pathologies. So can you list 5 local pathologies that can cause pain in this area? And just for your interest and save you the effort, plantar fasciitis or fasciosis is not one of them. Just 2 pathologies here, please, and give a little bit of thought to how they would present. Again, 2 pathologies and how they might present. Also, if you're interested, the music being played during this period is from the Elgar Variations. It's Nimrod. Okay, this is obviously metatarsalgia, which simply means pain in the metatarsals. So what I'd like is 4 pathologies. Metatarsalgia obviously isn't one of them. And again, how they would present, and in this case, how would your treatment vary? Okay, so heel pad pain. I know the most common answer to this is going to be plantar fasciopathy. It's not. Plantar fascial pain is anterior, so it's more distal to where this pain is. This is right over the fat pad. Plantar fasciopathy can refer backwards to the heel pad, but it's unusual to say the least. So no, we're not accepting that as an answer. The most obvious answer is fat pad atrophy. Or at least fat pad pathology, because there's a number of different types of pathology, and atrophy is one of them. This can be global, so the whole pad is atrophied, and this is usually due to systemic problems. Or you can have areas of it, and this is actually more common, I think. And certainly with plantar fasciopathy, where you change the way you weight bear, you start over-compressing some areas, and the fat pad gets thinner there. And it may only be the size of the tip of your finger, but you can palpate it. The characteristics of fat pad atrophy as diagnostic tools is that you can actually palpate the calcaneum, and that's actually what's tender, not the fat pad, but the calcaneum underneath it is. The fat pad can also be inflamed, in which case you won't be able to palpate the undersurface here of the calcaneum. You'll be palpating the fat pad, and this is where the pain is coming from. It can slip, that is partial dislocations, and then probably what happens is the calcaneum becomes more superficial because of the slip, and that's again what's much more difficult to try and find. You're going to have to palpate the extent of the heel pad and see if it has shifted off, and you can palpate the calcaneum on one side. It's going to be really difficult to separate that out from an atrophy problem, and you probably won't be able to do it in the clinic. It can burst with trauma, it just bursts apart, and what you can do then is you can palpate, and you can generally pick up the calcaneum through it. If you squeeze the fat pad though, you won't be able to touch the calcaneum, it won't be tender anymore, assuming that the fat pad itself isn't tender. This tells you that the fat pad isn't atrophied, it's just spread out and you can squeeze it together. And there's a tape job you can do for that. Or the fat pad can be contused. Again, direct trauma is contused, and the history now is one of trauma, direct trauma to the heel, whereas inflammation, you may not have that trauma. So that's one possibility. Subcutaneous calcaneal bursitis is another one. This is interposed between the skin and the fat pad, and it helps the skin move on the fat pad. But this can get inflamed, as any bursa can, and sometimes it can be so inflamed the swelling is actually visible underneath the skin. You'll pick this up with very superficial palpation, assuming the skin's not in trouble. This is very superficial palpation. Obviously, you've got to push harder. It's going to be more tender, but the fat pad won't be tender, so it's going to be difficult to tell. But superficial layer palpation will tell you what the problem is. The calcaneum can be fractured. This can be a stress fracture, a pathological fracture, or an overt fracture. The pathological and the overt fracture come on suddenly. The stress fracture may be slower and progressive. And of course then there's a mix of a pathological fracture with osteoporosis plus overstressing it. The clinical diagnostic criteria is a positive calcaneal squeeze test, where you squeeze transversely, or you can squeeze longitudinally through the neck of the talus and the back of the heel, and you just squeeze that way. One of those two tests, if not both of them, should be painful. And the same with the calcaneal cyst. Those squeeze tests hopefully will be painful. If not, you're not going to be able to diagnose it in the clinic. And you can have bone bruising on the calcaneum, so bruising, contusions, periosteoitis. And they're going to be difficult to pick up, but what you're going to get there is layer palpation is going to help you. So you'll get into the fat pad. It won't be tender until you really apply some pressure to it. So in that case, it probably is the calcaneum that's tender, but you really need to eliminate everything else before you actually make that diagnosis. Just distal to the fat pad on the medial side of the foot. This is plantar fasciopathy. This is so common as to outweigh all of the other causes we're talking about here by a lot. So almost certainly plantar fasciopathy, but not entirely certain. So fasciitis or fasciosis will give you pain here. You may also find tenderness as you run along the fascia towards the toes. That can be tender, and that may be also affected, or it may simply be referred tenderness along there because of facilitation. It's unlikely with a fasciosis that you'll be able to stress it using the weight-bearing toe-up test, but you might be able to pick that up with a fasciitis. But you're going to base it on essentially tenderness there and the history. Fasciosis will be pain on the first few steps, getting better as you walk further. Fasciitis is more difficult, but this will be exquisite tenderness when you palpate it, and the pain will get worse and worse and worse as you walk, and it won't get better with more walking. If it's not fasciopathy, then it could be a tendinopathy. They're the three tendons that run under that side of the foot from the medial malleolus can get inflamed or degenerate, and that can give you pain then, not terribly common. Or you can have a compression neuropathy through their Baxter's neuropathy, or tarsal tunnel syndrome, and the characteristics here will be neurological symptoms, paresthesia, coursalgia, and so on. You can have a distal calcaneal fracture. It's a bit unusual, and this could give you pain in this area. So, but plantar fasciopathy is almost certainly going to be what's causing this pain. And finally, metatarsalgia, which of course isn't a diagnosis, it simply means pain across the metatarsals. So, differentials include fracture or pre-fracture stress syndromes, both pathological and stress fractures, and obviously traumatic fractures. Traumatic fractures, the healthy bone fracture, the pathological fracture will have a sudden onset of severe pain. The stress fracture will have progressive pain. Bone contusions, post-trauma, you can actually bruise a bone or periosteoitis, and again the bone will be tender, and it's the same with the fractures. You probably need x-rays to differentiate between the two, although you can stress the bone, but if you suspect a fracture, it's probably best not to stress it, certainly not transversely. Bursitis is a very extensive burst that runs across the entire metatarsal area, and it interdigitates between the metatarsal heads, and this can get inflamed. This is about layer palpation again, and you may actually see swelling. Now the bursa can also get displaced with deformed feet, claw toes, hammer toes. Rheumatoid arthritis can displace this, and you can start then weight bearing on the metatarsal heads, and that becomes tender of the metatarsal heads when it is displaced. Morton's neuroma or other neuromas. Morton's neuroma really isn't a neuroma, it's an excessive collagen tissue, probably due to frictions between the metatarsal head, and then that can be painful in itself, or it can stress the nerve. But otherwise, neuromas are growths on the nerve. So if this is a true neuroma, you would expect neurological symptoms, so coursalgia, paresthesia. Freiberg's disease is necrosis of the head. It's rare, but again, this is going to show up much the same way as a fracture does. Palpation of the bone will be tender, stressing the bone will be tender. Capsulitis, I didn't know this previously until I started to look up things here, but second metatarsal capsulitis is often considered more common than shoulder capsulitis. I don't think you're going to be able to differentiate from arthritis, except it may be a single joint. Arthritis, again, so you worry, if this is multi-joint, then it's going to be something like rheumatoid in the foot. If it's a single joint without trauma, you still have to wonder why they have an arthritis present there. And I think you're going to have trouble trying to differentiate arthritis here from any of the other things going on. Just make sure this isn't bone pathology, after which probably any treatment you do is going to help. But get the bone pathology out of the way. If you've got any thoughts at all about this being bone, get it back to the physician for imaging. Okay, that's it.